Hello everyone, I am Nicole and Mandigo, and together with my groupmates we'll be talking about the vestibular system. So what is the vestibular system? It is a sensory system that is necessary for providing our brain about motion, head position, as well as spatial orientation. Moreover, it is significant in maintaining posture coordination, body position in space, which is essential for motor responses, and the eye movement that is influenced by the vestibular nuclei that sends projections to the cranial nerve nuclei. So these are the trochlear, abducens, and the oculomotor. So the saccule, utricle, and the three semicircular canals make up the vestibular system. The saccule and utricle, also called as the otolith organs, detect linear acceleration, whereas for the semicircular canals, detect the angular acceleration. So let's dig deeper and start with the semicircular canals. So let's first dig deeper into the semicircular canals. The vestibular system's principal components are found in the inner ear, which is in a series of compartments known as the vestibular labyrinth that is continuous with the cochlea. It contains the three semicircular canals situated or lie in different planes that are perpendicular to each other. Each canal can detect one of the head movements, such as nodding up and down or shaking side to side. The semicircular canal contains a fluid called the endolymph. These canals are continuous with the utricle at each end, and this fluid detects the plane of movement. The ampulla is a dilation that occurs at the end of every canal and opens into the vestibule. It contains a cone-shaped light structure called the crista ampullaris, which is composed of the special sensory receptors called the hair cells. Furthermore, a gelatinous mass called the cupula extends from the surface of the hair cells to the roof of the ampulla. So, the vestibular system has two other organs known as the otolith organs. Again, these are the saccule and the utricle. Let's first start off with the saccule. It is an ovoid sac-like structure that connects with the cochlea to the utricle via the canal reunions. It lies in the medial wall of the vestibule near the opening of the vestibular duct. The saccule detects movements in the vertical plane. Similar to the saccule, there is an ovoid sac-like structure called the utricle. The cavity inside is known to be the largest in the vestibular labyrinth. It lies in the posterior part of the vestibule and detects movements in the horizontal plane. Within the otolith organs, there's a small area that contains hair cells and supporting cells. It also composed a special sector or sensory epithelium called the macula. The macula of the utricle is in the horizontal plane when the head is in an upright position, while the macula of the saccule is in the vertical sagittal plane. The cupula of the utricle and saccule includes a superficial fibrous layer called the otolithic membrane that contains the otoliths and is attached by cilia from the hair cells. So lastly would be the vestibular sensory receptors, or also known as the hair cells. These hair cells are surrounded by supporting cells. And there are actually two types of hair cells, which are the type 1 and the type 2. For the type 1 hair cells, they are goblet-shaped, whereas for the type 2 hair cells, they are cylindrical in shape. Each hair cell has a single kinocilium, which are present at the edge of the apical surface. There are also a large number of tiny hair cells that are known to be called the stereocilia. The endolymph causes these stereocilia to move, in which neurotransmitters are to be released, which carry information about the plane movement to the brain. When the stereocilia are displaced toward the kinocilium, the hair cell is excited. However, when it is away from the kinocilium, the hair cell is inhibited. So when the head turns in the plane of one of the semicircular canals, the inertia of the endolymph exerts a force across the cupula, forcing it away from the direction of the head movement, causing the hair cells to be displaced. Movement of the stereocilia on the hair cells causes depolarization or hyperpolarization of the hair cells, whereas displacement of the cupula in the direction of the utricle causes excitation, while the displacement in the opposite direction causes inhibition. Linear acceleration or deceleration induces movements of the otolithic membrane and the cilia implanted in it in the macula, the saccule, and the utricle. The hair cells depolarizes or hyperpolarizes as a result of the displacement. The central pathways process hair cell excitation and inhibition patterns, which are interpreted by neurons in the cerebellar and cerebral cortices to provide a sense of equilibrium or sense of balance.
Hello, so I will be talking about the vestibular pathways. The cell bodies of the first order vestibular afferents are found in the vestibular or the scarpus ganglion, which is located at the distal end of the internal auditory meatus. Their axons travel through the internal auditory meatus and the vestibular portion of the 8th cranial nerve and enter the brainstem at the junction of the pons and the medulla, where the 4th ventricle is the widest. The majority of these afferents project to one of 4 vestibular nuclei in the rostral medulla and caudal pons. Some vestibular afferents travel directly to the cerebellum via the inferior cerebellar peduncle. The central pathways. Although the vestibular ganglion is referred to as a single ganglion, it actually contains 2 vestibular ganglia. The peripheral processes of the neurons found in the vestibular ganglion innervate the receptors or the hair cells in the vestibular labyrinth. The ascending vestibular pathways. So, the ascending axons of the neurons located in the superior vestibular nucleus enter the medial longitudinal fasciculus or the MLF rostral to the abducens nucleus and project ipsilaterally to the trochlear and oculomotor nuclei. Fibers from the neurons located in the medial vestibular nuclei also ascend in the MLF, or the medial longitudinal fasciculus, and project bilaterally to the abducens nucleus, contralaterally to the trochlear and oculomotor nuclei. Cerebellar afferents and efferent projections. A vital source of inputs to the cerebellum arises from the vestibular system. Afferents can enter the flocculonodular lobe either directly from the vestibular apparatus or indirectly, primarily from the medial and inferior vestibular nuclei. This indirect route allows a greater number of fibers to reach the cerebellum. The lateral vestibular nucleus also receives both excitatory and inhibitory signals from the cerebellum. Excitatory inputs originate from the fastigial nucleus, while inhibitory inputs to the LVN arise from the Purkinje cells of the anterior lobe of the cerebellar cortex. The vestibulocortical pathway. Some axons from secondary neurons in the superior and lateral vestibular nuclei are presumed to communicate with the cerebral cortex. This may be accomplished through bilateral projections of these nuclei via the MLF to the thalamic ventrobasal complex and from the thalamic nuclei to the cortex. This shows the possible pathway from the dorsal column medial lemniscal system that mediates conscious perception of body position in space and sensation of movement. Lastly is about the descending vestibular pathways. The lateral vestibulospinal tract arises from the lateral vestibular nucleus, descends through the brainstem, and terminates in the ventral horn of both cervical and lumbar levels of the spinal cord. Lateral vestibulospinal fibers descend ipsilaterally and compellingly facilitate extensor motor neurons via the transmitter acetylcholine. Projections from the medial vestibular nucleus descend bilaterally in the medial longitudinal fasciculus as the medial vestibulospinal tract, terminate in the cervical spinal cord, and serve to adjust the position of the head and neck.
There are a plethora of disorders associated with the vestibular system. A great example is nystagmus. Nystagmus is the repetitive movements of the eyes due to the movements of the visual field. The eyes move rapidly as the focused object becomes out of the field of vision. This movement is described as saccadic and would describe or indicate a lesion in the brainstem or in the cerebellum. There are two types, such as pendular nystagmus, where the nystagmus is in equal velocity in both directions, or it is jerk nystagmus, where there's a slow phase of movement followed by a quick phase in the opposite side. Nystagmus can be due to a lot of things, such as stated, the lesion, or the lack of development in normal eye movement, albinism, or even high refractive error such as myopia and astigmatism. A test such as a spontaneous nystagmus test can be used to test for this disorder. When sitting with the head and eyes in a neutral position, the spontaneous nystagmus test evaluates if the patient has any nystagmus, with or without fixation. Frenzel and goggles are worn to impair the eye's capacity to focus, making nystagmus more visible if it exists. Vertigo is another example, where the individual has the sensation of turning in the absence of actual turning, and is accompanied by nausea, vomiting, and gait apraxia. A possible cause of this is the peripheral vestibular lesion that affects the labyrinth, cranial nerve 8, or even central lesions that affect the brainstem vestibular nuclei. It could also be a benign paroxysmal positional vertigo or BPPV, infection, or even migraine. A caloric test can be used to test for vertigo. It is an effort to see how responsive the vestibular system is and how symmetric the systems are between the left and right ears. The caloric test works on the principle that heat or cold affects the density of the watery endolymph in the semicircular canals. The shift in density alters the balance of force throughout the pupillum, resulting in neuronal activity that resembles continual acceleration. The basic premise behind caloric stimulation is that normal labyrinths respond symmetrically and measurably within a previously established normal range. Peripheral dysfunction is indicated by the lack or slowed response. Motion sickness is a common disorder in the inner ear that is due to the activation of autonomic centers by the afferents from the vestibular system. This is caused by repeated motion, most commonly like in a car. Although any lab test is not commonly used to test for motion sickness, one notable way to test and treat or mitigate motion sickness is to do motion sensitivity exercises. This is a controlled yet quick movement of the head and body that typically triggers motion sickness in a controlled environment. This can also be used to treat this disorder by using the concept of desensitization. Meniere's disease is commonly found with intermittent relapsing vertigo, hearing disorders such as tinnitus, and generally distorted hearing. This is due to the heightened accumulation of endolymph, which could be due to poor drainage, edema of certain hair spaces containing endolymph, and damage to the respective hair cells. As of now, there is no treatment, but it is possible to relieve symptoms with steroids and diuretics. To test for Meniere's disease, video histamography can be used. This exam assesses eye movements to determine balance functions. Sensors in the inner ear that control balance is linked to muscles that control eye movement. You can move your head while keeping your eyes fixed on a location thanks to this link. In this test, the video cameras and electrodes can measure eye movements to assess indicators of vestibular function or neurological issues, which is an important step in the diagnosis of vestibular illnesses. These tests are usually carried out in a dark or dimly lit environment, where the examiner asks a series of questions in order to keep the person being tested occupied and alert. The inflammation of the labyrinth, a component of the inner ear, is known as labyrinthitis. Inflammation of the 8th cranial nerve, or even a virus or bacteria, is a possible cause of this disease. Vertigo, hearing loss, and other symptoms are caused by the inflammation of this structure. Most people's symptoms fade away with time. To test for labyrinthitis, a complete physical and neurological evaluation should be used. Some tests to be used and to rule out other related disorders are hearing tests, blood tests, EEGs, CT scans, MRI scans, and ENG.